This is a post-femto uneventful cataract surgery where there is a complete back pull created during irrigation aspiration, the result of nearly 140 degrees of capsular bag being accidentally pulled during irrigation aspiration. So we are going to see how this is managed. Watch carefully. The whole bag has been pulled while doing irrigation aspiration. This a lot of times can happen by mistake or at times when the low infusion pressure is there. As you notice, the moment the bag is pulled and it is realized that there is a complete breakdown of the zonules there, the surgeon actually stops the surgery and goes in for the reflux. Once the reflux is done, you have to make sure you suddenly don't withdraw your irrigation port, but instead you slowly stop the infusion and use your left hand to instill viscoelastic to maintain the anterior chamber. One word of warning is always make sure that the viscoelastic goes into the bag rather than into the anterior chamber, because if you push it into the anterior chamber, it can actually break the hyaloid phase and get into the vitreous and actually promote vitreous protrusion into the anterior chamber. Once that is done, according to the axial length or the white to white of the patient, you can select the CTR ring. In this particular case, since this patient was needing an IOL power of 24.5, we went in for a 11 to 12 millimeter diameter CTR. Before putting the CTR, make sure that the anterior chamber is adequately distended with viscoelastic but not over distended. Over distension in this case can cause the vitreous again to come into the anterior chamber. Second thing to remember is while dialing the CTR, it has to be a very slow controlled movement which is being directed towards the tangent of the part of insertion at the wound. And while doing so, you have to make sure that there is no undue pressure being exerted in that area where the breakdown of zonules has happened. As we will see in this particular situation, we will look for an instrument, for example, a Sinskey instrument in this particular case, to dial the CTR in. And the trick is to go under the anterior capsularis margin and then release it in one go. Slow motion will again describe the motion in great details. As you go inside, you actually make sure that the loop goes under the rhexis margin, and once you are there, just tilt your Sinskey loop and release the hook. And the moment the hook goes inside the capsular bag, you will realize that the whole bag distends and starts looking far more stable. So now major part of the surgery is over now. Now we go towards the cleanup of the cortex, which unfortunately not only in the periphery but also all around the posterior capsule, extending from one edge to the other edge, covering the posterior capsular bag also. So we will go with a Simcoe cannula with a bottle height reduced to around 70 to 80 centimeters and go on looking for loose tags of cortex which can be initially pulled comfortably and without any pressure. One word of caution, while pulling these tags, if you feel that the whole bag complex is being pulled, you must resist the temptation to pull further. Like you would see this, the moment a capsular tag is separated, you can continue to pull that tag across the posterior capsule down to its final destination where the whole cortex can be removed. You will notice when we pull those tags which are entrapped under the capsular ring, the whole bag moves, which means these cortical tags are actually stuck behind the endocapsular ring. We should be very careful while pulling these tags, and especially in the region where the zonular loss has occurred, because if we pull too hard, we can end up pulling the whole ECR complex or the endocapsular ring complex along with the bag and further causing a dislocation and landing in trouble. Another tip is to pull the cortical fibers more so in a radial manner away from the zonular loss area, and at times in a tangential manner, especially in those zones where the zonules are lost. We also have to remember to instill viscoelastic off and on to distend the bag and ensure that the vitreous hyaloid face is being pushed back and doesn't tend to protrude from the area of zonular loss. Once the viscoelastic is again instilled, we also have to remember we do not overpressurize the anterior chamber with viscoelastic lest we'll cause more subluxation of already broken zonular bag complex. Now once the viscoelastic is instilled in the anterior chamber, we again use visco with very slow pull-push technique, which means we pull the cortical tag, engage it, and then once it starts coming out, we release it again and go and engage more broader part of that triangular cortical tag, thus making sure that the distribution of the pulling force is more equally distributed over more broad area within the capsular bag. This will ensure that we have more complete and controlled cortical plate removal. Especially for the subincisional area, you can attempt to remove the subincisional cortex using the Simcoe, but at times it can be very tricky, as we will notice now in this video. We will fast forward this irrigation aspiration for you to understand that the finer nuances of doing this very carefully is very, very important. We can land up in big trouble if we do not use care while pulling these cortical tags. Now, if at times we feel we are stuck up in a situation and we need to leave some amount of cortical tag, you can actually safely leave these cortical tags also. But in case you have access to a bimanual cannula, it is recommended that you instill viscoelastic, make the eye a little turgid and use a bimanual cannula, especially to remove the cortical matter which is in the subincisional area. One common question often asked to me is, why not use a bimanual irrigation aspiration to do the whole procedure right from the start the moment a zonular tear was noticed? But in my opinion, when we instill a bimanual irrigation aspiration cannula with the amount of fast fluid gushing out from the irrigation port, a lot of times we unnecessarily may cause extra hydration of fluid going into the vitreous cavity and thus create a problem where we don't have any other problem pre-existing. Now, before we draw the irrigation port, as mentioned earlier, we ensure that some amount of viscoelastic is instilled into the bag to make sure that the bag is distended again. Now we proceed to put a hydrophobic IOL into the bag. Now again making sure that we don't dial the lens but rather slowly and softly nudge it into place. Another good point is to remember so that we place the haptics of the lens directed towards the maximum breakdown of zonules, which is in this case nearly approximately 30 degrees to the orientation of the eye. This actually gives extra support to those broken zonules and actually distends the bag in that direction to avoid any viscoelastic going into the posterior part of the chamber or even fluid which might during the irrigation aspiration get into the posterior cavity. Now once that is done, we can further go ahead and remove any other remaining cortex, because now we are practically sure that the bag is properly distended with an ECR in place and also a rigid haptic of the hydrophobic lens pushing that part of the capsular bag where the zonules have lost their integrity. This will make sure that the lens stays in place and there is no fluid of irrigation aspiration going behind from the side of the broken zonules into the vitreous cavity. Once this procedure has been done, before we close the eye, we once more ensure in this particular case that if there is any free floating cortex which is caught behind the haptics or the optic of the lens, with slow gush of fluid of 27 gauge cannula, slowly directing the fluid into those areas of the anterior capsule where there could be some residual cortical matter. But a beginner need not worry, you can at times leave some cortical matter in this area. Here we will instill some meiotic agent, carbachol in this particular case, to constrict the pupil over the IOL to notice two things. We will notice that the pupil becomes absolutely round, which means that there was no vitreous loss in this particular case, and the case is completely done without any untoward situation. Thank you.